I was going to present on new immunotherapy, specifically immune checkpoint-based approaches in acute myeloid leukemia and myelodysplastic syndrome. There has been a significant amount of progress both in understanding preclinically as well as in expression of different immune checkpoints in AML MDS. Our group at MD Anderson has been working on this now for the last 5 to 6 years, and some of our initial publications have shown that there is actually quite a well preserved T cell population, both in the bone marrow as well as in the circulation in patients with acute myeloid leukemia. This seems to be most well maintained in the newly diagnosed AML as well as in the early salvage, salvage 1 and 2. And as we get to subsequent salvages, probably because of the effect of high intensity chemotherapies, pure analogs that patients get, as well as inherent to the multiple relapse nature, we do see that the immune system becomes more and more abrogated, and then it is difficult to start seeing circulating T cells. The other thing that we have noticed of interest is that when we looked across multiple different immune checkpoint co-receptors, we had a panel of 10 of these, including PD1, CTLA4, TIM3, LAG3, GITR, others. PD1 and OX40 seem to be the two checkpoints that were expressed at higher levels in the bone marrow microenvironment T cells in AML, both in newly diagnosed as well as in the early relapse. So this has led to studies that are combining hypomethylating agents with PD1 inhibitors as well as CTLA4 inhibitors that are ongoing now at MD Anderson as well as at other sites. And some of the initial data that we have published, specifically the azacitidine with PD1 inhibitor nivolumab in the salvage population, have shown encouraging response rates. The overall response rate was about 35%, which compared favorably to a matched clinical trial cohort of patients who received other azacitidine combinations in similar salvage on other trials at MD Anderson, where the response rate was about 15 to 20%. So we do think that there is a signal for early response, especially in patients who did not have a prior hypomethylating exposure. Those patients had a CR/CRI rate of almost 55%, which is very encouraging for a relapse population with any HMA combination. And as we had predicted by the preclinical as well as expression data, it is the patients who are salvage 1 who had the best improvement in survival, where we were seeing a median overall survival of 10.5 months, which in salvage 1 is really quite encouraging. Now, this was a single center study, so we have to see if this will hold true in larger multi-center studies, and these are being considered. In addition, what we saw is that when we did the HMA azacitidine plus PD1 inhibitor, there was an increase in one of the other counter-inhibitory pathways called CTLA4. This is something that has been shown multiple times in solid tumor, that when you block one of the major co-inhibitory pathways for T cells, such as PD1, the T cells are intelligent and escape by CTLA4 upregulation. So this has led to combinations, as many of you know, as well as FDA approvals in melanoma, lung cancer, others, of combination immune checkpoint blockade. And we are now exploring the same, where we're doing a combination of azacitidine plus PD1, which was found to be safe and showed some encouraging response and survival in early salvage, and adding to that the CTLA4 inhibitor. And I had shown some of this data at the ASH meeting, where we are seeing that the response rates now, the CR/CRI rates, are going up to about 45% compared to 30-35% with the AZA plus PD1 alone. And quite interestingly, people who have extramedullary disease, skin, lymph node, are having very striking responses. We had 4 such patients, and all 4 of them had a response to the azacitidine with PD1 with CTLA4. This is something that another group from Dana-Farber actually did show and published almost 3 years ago now in the New England Journal, where they found in people with post-transplant relapse, specifically extramedullary disease, they had a very striking response to single-agent ipilimumab CTLA4 inhibitor. So we do think for extramedullary disease especially, there may be a very good niche for the development of ipilimumab, either alone or in combination with azacitidine nivolumab, as we're doing. And we are preferentially putting patients with extramedullary relapse, as well as patients who have post-transplant relapse, on these immune modalities, where there seems to be the clearest benefit. Also, because this is also a population where there's limited other therapies that work for extramedullary relapse as well as for post-transplant relapse. So I think there will be much more updates on this. There are also multi-center studies, including 2 maintenance studies that are ongoing, one in Europe with the German cooperative group using pembrolizumab with azacitidine as a maintenance post-induction consolidation with standard cytarabine anthracycline. And in the United States, there's a randomized maintenance study of best supportive care/observation in patients who have completed their planned induction consolidation for AML. Now, also, it has to be noted that there were a couple of other presentations at ASH this year, some of which were positive and some of which were not as positive. So the one that was not as positive was a randomized frontline phase 2 study that had two cohorts, AML, MDS, about 100 patients in each, 50-50 randomized to receive azacitidine or azacitidine with durvalumab, which is a PD-L1 inhibitor. And what the authors showed was that there was no significant improvement in either CR/CRI rate or median overall survival in either AML MDS with the addition of the durvalumab versus AZA alone. They did not find any concerning efficacy signal, and the immune toxicities such as itis were manageable, but there was no clear response or survival benefit. Now, our group has actually looked at PD-L1 inhibitors, and we also showed data at ASH this year where there actually may be quite a significant difference between PD-1, PD-L1. And in fact, in our experience with EbolaMap, which is another PD-L1 inhibitor, when we combine azacitidine with EbolaMap, we found that almost all the patients who did not respond had a significant upregulation of PD-L2. This was 7 patients analyzed by mass cytometry. So we think that PD-1, which blocks both PD-L1 and PD-L2, is probably much more effective than PD-L1 inhibition alone, where the escape may occur through PD-L2, which is left unchecked. And this is actually emerging true in solid tumors, where the PD-1 inhibitors are showing more potency and durability. So there may not be the same as many people thought. Now, lastly, when we talk about immune checkpoints, there's a very, very exciting immune checkpoint that has emerged for MDS and AML. This is actually not a T-cell checkpoint, but a macrophage, another component of the immune system checkpoint. The drug is called CD47 antibody magrolimab. And there was data presented this year at ASH by Dr. Salman, where he showed that in the patients with newly diagnosed MDS, the overall response rate with a combination of azacitidine and magrolimab was 90%. This compares very favorably to historical overall response rates of about 40 to 50%. And even if we look at the true pure CR rate, which is really the gold standard that the US FDA looks for, the true CR rate was 50%, 50 with the azacitidine magrolimab, which compares very favorably to the 10 to 15% CR rate that has been reported even in contemporary studies with azacitidine alone. And similarly in AML, especially in the high-risk TP53 AML, the combination of azacitidine magrolimab was giving 70% CR/CRI, which is actually better than we get with HMA venetoclax, which we all know is approved and one of the choice frontline regimens. So we think that this macrophage checkpoint, which unleashes the macrophages by blocking CD47, may be one that is very specific for AML MDS and also maybe in follicular lymphoma, and maybe the checkpoint for heme malignancies. Just as for solid tumors, it may be PD-1, CTLA-4, and eventually, potentially, this could be combined with venetoclax or with PD-1 and other approaches. So I think that is a drug to watch out for and hopefully will lead to registration in the near future as the studies mature. So that was really the highlights of what I was going to talk about, and I'm happy to take any questions. The toxicity is the important thing to be aware of. There are unique toxicities that are seen with the immune checkpoints, especially with the PD-1 CTLA-4. And in our experience, we've treated more than 300 patients across AML MDS with different PD-1 CTLA-4 single agent and combinations. These are actually quite manageable, but there is a learning curve. And I have to say in the initial 1 to 2 years, there were a number of immune itises that occurred that were missed. And in AML, the predilection seems to be especially for pneumonitis in the lung, which is a really difficult challenge because that is also the common site of infection. So there will always be the question in somebody with AML, relapse, low ANC, neutrophil count, came in with fever, cough, shortness of breath, hypoxia. Is this a pneumonia? Is this a pneumonitis? And what we have come to start learning through our extensive experience with these drugs is almost in majority of the cases, I would say, turns out to be pneumonitis. Of course, you cannot rule out pneumonia. So we have to treat both in parallel because delaying therapy for either could actually lead to IC even more than solumedrol or steroids, usually 1 mg per kg Q12. In parallel, broad antibiotic antifungal, as we would do for neutropenic fevers, get ID pulmonary, And I think more and more we're seeing that the steroids work as a diagnostic and therapeutic test. So within 24, 48 hours, if the patient dramatically improves off oxygen, feeling better, this is more likely the steroids, especially if the cultures, nasal wash, viral panels come back negative, and then we will slowly wean antibiotics. But I think this has been an issue with many of the multi-center studies, including the one that I said, where recognition of the immunitis, especially pneumonitis, but also, for example, colitis can be seen, rash, liver enzymes. The good thing is, if identified, 90% to 95% of them will respond to steroids very quickly, usually within 48 hours or less.